Howdy folks, and you're listening to the Speak Up podcast, your number one topical discussion podcast surrounding all things mental health. I'm your host Ashley, and in this episode 4, I'll be talking to Zachary Kellerman, who is a former therapist with some psychiatric training, who's been involved professionally in various different roles within the sector. He's also got his own personal story, personal lived experience of mental health, and has a diagnosis of MDD, major depressive disorder, otherwise known as treatment-resistant depression. Now, what that means is that he's failed to respond to sort of like 3 or more medications or therapeutic interventions. But I'll talk more about that in the episode. The episode itself is quite long. The full episode is about almost 2 hours, guys. So what I'm going to do is compile them into this little preview, this little 3-part segment. In the first part, he's going to talk about advocacy and fighting the system, right? Fighting the system and things like that, and complaining and following the right procedures. In the second part, we're going to talk about, or rather he's going to answer my question, where I asked him, if I appointed you as Director General of the NHS, how would you fix this crisis? He's got some very interesting views on that, folks. And thirdly, in the third and last part of this segment, we're going to talk about TMS therapy and what he believes is the way forward for his condition for the treatment of treatment-resistant depression, which is ketamine, guys. And now ketamine is not widely available on the NHS. It's a controlled drug. However, it's been used in clinical trials on the NHS in select locations and select hubs, and he talks very passionately about ketamine and how he took part in a clinical trial, guys, and how it's helped him. He doesn't have access to the drug. However, he's a great believer and advocate of ketamine to be introduced routinely in the NHS, and he's fighting to open up a clinic around ketamine and things like that, and going through the various channels. It's a great honour and privilege to have Zach on the show. He's done a lot of different types of roles within mental health as well, and he's currently involved in governance on his local NHS Trust board. So guys, just as a disclaimer as well, as I usually say, we're not a medical podcast, so any information that we have on this podcast herein is not intended to be a substitute for your GP's medical advice, guys. I'm not qualified to give medical advice, okay? And to a certain extent, neither is Zach, although Zach does have some psychiatric training and he's a former therapist, guys. So, however, always consult your GP first, guys. So, without further ado, I hope you enjoy this clip. It's about 26 minutes long. It's an excerpt of the full episode 4, which is with Zachary Kellerman, guys. I hope you guys really enjoy listening to it, and I hope to have the full episode out to you very soon. Take care, guys. Bye-bye for now.
And I say you fight for that. Everyone, it doesn't matter what your diagnosis is, you have more power than you think. It is frustrating, and you shouldn't have to be fighting for basic dignity and treatment.
Yeah.
But please do.
Yeah.
Please do. Even if you feel you're seen as a problem patient, trust me, you're not. And again, that's what your governors are there for. Please go to them too, and put in complaints, because services don't, and pester them as well if you have to.
Yeah, that's
your MP as well.
Yeah.
Go to your MP. Do whatever it takes, because at the end of the day, it's your life.
Absolutely. Yeah.
Everyone deserves a good quality of life, no matter what.
So what would your answer be to the crisis? If I was to appoint you as Director General of the NHS, how would you fix the system?
Oh, God.
Yeah.
Well, there's talk of parity of esteem. This talk of parity of esteem has been happening since about 2010. It's a conservative idea, like conservative government idea. If we equalise the amount of funding that physical health care gets to mental health, roughly, it's been a while since I've looked at these figures, but roughly mental health care gets about 8 to 10% of the funding that physical health care gets. Yet mental health, affects 1 in 4 people. So parity of esteem means you have equal funding in proportion, We don't have that. We still don't have that. What we've seen over the last 12 years, Conservative rule, it is cuts to specifically mental health systems and learning disability services as well, because they're the most vulnerable and easy to cut, because we don't have, and this is why podcasts like this are such a great outlet and a needed outlet, because change doesn't happen quickly enough internally. And I do what I can in my roles to change things, and I do. I am changing things, but it's just one person. This is why a larger voice, larger platforms like this are so important. So first, we need a true parity of esteem. We need that funding. Whether that means we're taxed higher, which it probably does. We need to do that. We need to pay NHS staff more.
Yeah.
We just do. I fully support the strikes. I know I don't want to get political, but there is a good reason for the strikes. The average nurse, I think, does not get paid what the government are saying they get paid. They're getting paid. They get started on about 23, 24K, and they go up to creep up to 25 to 28, and they stay on that for most of their working lives. Yeah, it's not good. They got rid of all the good pensions that the NHS used to get when it was better funded. There's no, so yeah, fund nurses. We need a lot more in-house training for psychiatry. I think there's like 2 schools. I mean, don't quote me on this because it's not something I've looked into. It's something I've heard about. So I could be wrong, but there's like 2 schools that specifically teach psychiatry in the UK, probably down south, might not be down south. I think there's one in Scotland. But we need to be teaching this as a speciality. We need to be reforming education around mental health. A lot of people talk about the best interventions are early interventions. That doesn't help people like me that's suffering now. And for instance, maybe people like yourself, Ash, and a lot of listeners in this podcast, but we need early intervention too. There's a lot of people that have been campaigning for child and adolescent mental health service budget increases and getting people in schools taught mental health. A lot more is being done today than it was when I was in school. It's still not enough, but we do need to focus on early intervention, but we also need to focus on the people that are living it day to day, because that's where the funding drops off. It's for people like myself, maybe people like you, Ashley, maybe people that listen to this podcast. So early intervention and people that, because the early intervention didn't work for me. I got early intervention. I'm still very ill. They're still going to get a subset of people that even with early intervention are still going to develop a serious mental health issue. And it's not a death sentence. What makes it a death sentence in this country for 99% of cases, not everyone, I think there are some people that just become way too unwell, unfortunately. But most cases, I think, if the treatments were there, the modernisation of treatment was there, like the ketamine as an example, like the psilocybin as an example, we'd have people giving back a lot more to the economy. I know that's what the government loves to hear. We'd have people that weren't reliant on benefits, because nobody wants to be reliant on benefits.
No.
Nobody wants to be out of work. People want a fulfilling life, and work, a lot of people are overworked, but work is a big part of people's lives these days.
Identity,
Yeah. And so the current system's just not working. It needs reform.
Yeah.
And I know it's happening. There's a lot of community mental health transformation that's happening across the country. But the way they're doing that is often getting a load of patients volunteering loads of hours of their time, not always, but loads of hours of their time, to tell them how they should run services. Because I've been involved in these things myself in more than one organisation, these transformation, mental health transformation things. They will take it in, but it goes in one ear and goes out the other.
Yeah.
So we need people that have lived the experience at top positions, telling people and being listened to what should change. Again, funding, we need to be paying our staff actual competitive wages, not just against the private sector, but against comparative countries. You go to Australia, a lot of my nursing cohort that I knew, a lot of them have moved to Australia, and you know why that is? Because they get paid twice as much as they do here.
Yeah.
And you get the weather. So there's no competition at all.
A recurring theme that I'm hearing now from obviously from your answer to that is a lack of funding, a rigidness to change, and also a lack of salary for nurses and quality professionals.
And the last thing is a culture change as well. This hierarchy needs to go. There needs to be a lot more person-centered care as well. This IAP stuff, it helps people with predominantly it helps people, should I say, with low-level mental health issues. So, but 49% as a national average of how many people get benefit. And that benefit can be as low as a 1-point increase in mood and anxiety on the scales that they use. It needs to be more robust. There needs to be more options there. You need to fund therapy like we used to have, not just psychologists being able to provide long-term therapy or, step-free, whatever, of IAPT. You need to fund counsellors and psychotherapists. We've got, I think it's 20 to 30,000 trained counsellors in the UK, and they get trained for several years and get a few hundred hours placement experience to be able to do what they do. 20 to 30,000 that are not employed by the NHS, that are just waiting to be employed. A lot of them are forced. Therapists don't want, a lot of them, not all of them, don't want to go into private practice. They're forced into it because the NHS does not want to recognise counsellors. They don't want to have that as part of their service. Some trusts, some NHS organisations are starting to change that, but on a national level, it's not happening. So you've got 30,000 counsellors out there, ready and trained, would love to work for the NHS, but there's no jobs going there unless they train in the IAPT model of working, which 49% of people only benefit from.
Yeah.
So I got the transcranial magnetic stimulation on the Monday. So I waited the weekend, and we were down there halfway across the country, travelling there 4 times a week to get this treatment. And as a part of that, to stabilise me, so, I didn't die as his prognosis was, I was given ketamine. And this was on a clinical trial, so this was completely free. And there are currently clinical trials happening for ketamine. There's a lot of promising research on it. And it's literally, so it was an IV ketamine, so intravenous ketamine, to again stabilise my mood. Whilst the TMS was a lot more invasive, transcranial magnetic stimulation, TMS, a lot more invasive, and it took not as invasive as ECT. Mind, it feels like you're getting a tattoo on your brain, which sounds horrific. Again, it just feels weird when you get used to it. And basically, to put that in a nutshell, they thought that both worked, but what I felt was that the ketamine worked, especially that was the thing that worked. If there's anything that's ever worked for me in my position, it's ketamine. I've heard people talk about this like off switch for their mental health. That they've had this treatment, it's suddenly like everything's clearer, and I've always used to think it was BS. I'm still quite skeptical about it, but I had this ketamine treatment, and after 2 free these injections, so basically they inject it, they give it an hour to go through your system, and they flush it out. So you're really high for that hour, really high. I mean, that felt really good, to be honest. But they flush it out your system, so it's gone after the hour, and then you just get the residual effects of so you're not high anymore. You're you. But it was like an off switch in my brain. All that noise, all that self-doubt, all that difficulty with thinking, being able to have cohesive thoughts. I mean, you probably hear throughout this recording that I'm a bit all over the place. And again, that's untreated severe clinical depression. It's hard to concentrate. It's hard to... I used to really love reading. That used to be my number one. I was such a nerd. I used to absolutely love reading books. I'd sit up all night, read loads of books. And I can't do that anymore. And depression's robbed me of that. I can't sit and read a book, which is it really upsets me whenever I mention it, because it's embarrassing. It feels embarrassing. I know it's not embarrassing to the wider world, but you just can't concentrate on those words. That's how bad it gets. You can't read anything without having to reread and reread to the point you get really frustrated. The ketamine treatment, it was like I was never mentally unwell, ever. Like, I didn't know what that was.
After an epiphany for you, really. Epiphany moment.
I felt, and I hate using the word normal, I felt normal. I felt normal, completely normal, like or should I say a baseline that a person, an average person without health complications should feel like.
Yeah.
I mean, it lasted because of the nature of the clinical trial, so I didn't get the top-up treatments that people would get. Now, this isn't really available on the NHS, should I say.
Yeah.
Again, there are clinical trials that are happening. So if this is something you hear of and you think that might be for me, look them up. Just look up, Google ketamine clinical trials UK.
It's available privately though, isn't it? But not on the NHS. So
it's available privately, mostly in London, but it costs about 15 grand.
Yeah,
nobody can afford that so money does make the world go around, sadly.
Yeah. And this is the way forward for your condition, in your opinion, would you say?
Well, it is. This and psilocybin. So I've been fighting for a ketamine clinic up here. So there are currently 2 ketamine clinics in the UK, right? There's one in Oxford and there's one in Northampton. If you live in those areas in the NHS, you're golden. If you're someone like myself with my condition, treatment-resistant severe major depression, it's not responded to God knows how many treatments. I mean, the NICE guidelines, I believe, say 3 different combinations of treatments, but really it's a revolving door of treatments.
Yeah.
Even then, you don't really get diagnosed with it officially. You just try more and more treatments until it screws your health up completely. But that's, yeah. So if you're in my position, if you're in Oxford or Northampton, then bloody hell, go for it. Go for it tomorrow. Just push for it because it's available on your NHS. And they fought for it. Both these places absolutely fought for it. It's very innovative. I mean, but privately, yeah, about 15k, probably even more than that. It's hard to find the exact numbers on these private clinic websites because they like to be a bit coy about it. So it's about 15k then.
Yeah, still, I always thought that ketamine, it has this kind of cloak of illegalness around it, like it's still considered an illegal drug or used in very restricted circumstances for like animal care and.
Yeah. So ketamine. So the reason that NICE, so the National Institute of Clinical Excellence, who oversee what treatments are available on the NHS, it's been put forward to the NHS so many times, it's been rejected so many times because the company Janssen Janssen, the pharmaceutical giant, they hold the patent to S-ketamine, which is basically just ketamine in a nasal spray formulation. There's nothing else particularly amazing or different about it. It's just ketamine as a nasal spray. They put a patent on that, can charge what they want. They charge 10.5k per patient to the NHS. So this gets put to through the NICE guidelines for review as to whether the NHS can afford to fund this. They turn around and say no. Despite the NICE guidelines specifically saying there's a dire need for treatment-resistant for treatment-resistant depression. Depression is the number one, from what I'm remembering off the top of my head, might not be anymore, but it probably is, especially these days, number one global disease burden across the world. So, i.e., it costs economically, socially, causes a lot in terms of livelihoods, lives, the most loss out of any illness. For 10.5k to me, it's nothing. I know to an NHS trust, they're going to think, Jesus, 10.5k for one person, that is a lot of money when we can put them on generic antidepressant A, which hasn't worked for them 5 times in a row, that costs us on generic, £6 for a pack of 40. But the thing is that the NHS doesn't, in my experience,
the short-sighted, aren't they?
Yeah, they think of what's going to be cheapest and easiest here and now. But the thing is, they don't think of the long-term plan. In my experience, again, I must preface that. I don't want to get in trouble with work. Not that I think I would, but anyway, just in case. It tends to be, here's short treatment and cheap treatment 1. That hasn't worked. Here's short treatment and cheap treatment 2. And then it goes on and on and on. Instead of looking at more expensive, more effective treatment C, They just look at that treatment A that's cheap and effective again and again and again. And they're
going around on a merry-go-round, aren't you?
You do, and you do. You absolutely do. And I wonder how much that actually costs the NHS to continually do that. Now, so NICE guidelines basically said, no, it's 10.5k, that's too expensive. The patent that they hold, from what I read, it could easily, we could easily have generic versions of S-ketamine, so the nasal spray, as early as next year. I don't think it would be that early, personally. From people I've spoken to, it's going to be at least 10 years. So we have the option of the intravenous ketamine, literally the ketamine injections. Those cost, right, get this, for one dose, and a typical person probably get about 6 doses, maybe more, up to I think up to 12. But again, I have a very unreliable memory. Again, ECT, don't recommend it. Reason why: about 5 years of my memories have just gone from that. I know that doesn't happen to everyone, but I cannot remember long-term things anymore, which is not nice. But yeah, that aside, this would be an alternative to things like ECT and these quite archaic. I know they've modernized these archaic treatments, but they're still archaic options that we have out there. So intravenous ketamine costs £8.77 per dose, and you get about 6 doses. I know antidepressants that are prescribed very commonly, especially augmented medications. So typically with a treatment resistance, which up to 30% of people will have a treatment resistance, will get augmented with a second medication. So if medication A doesn't work, you up that medication, usually twice, and it's still not working, and you've been on several other medications. Oh, let's add another medication into that. The problem there is, one, you then tripling the cost of those medications to that patient on an NHS perspective. Secondly, the patient perspective, you're doubling, tripling the side effects, long-term side effects as well.
Yeah.
And free, with some of them, like for example, risperidone, some antipsychotics, again, other antipsychotics in that class, a lot of weight gain that happens. There's already a big link between type 2 diabetes and a lot of mental health medications that are prescribed these days. I'm not here to scare anyone off, but there is evidence there that links these. It's not hard to find if you Google it.
Yeah.
So there are long-term health conditions. Things like lithium absolutely destroys your liver. On average, it can take about 20 years off somebody's life if they're on it long-term, lithium. It's one of the few medications I wouldn't be on. And another one that I want to call out is mirtazapine, which is very commonly prescribed these days. And the reason I call out mirtazapine, it is quite an effective medication, heavily sedating, and you are guaranteed weight gain. I don't care what psychiatrist, GP that don't really get any training in mental health, by the way, will say mirtazapine will make you gain weight because it kills the switch in your brain that tells you you're full, that tells you to stop eating. So you're going to feel hungry 24/7. And they used to use this off license or unofficially. They used to prescribe this because I've seen it. They used to prescribe this. Not always. It's not. I'm not saying there's no conspiracy here, but I'm saying it's just bad practice I've seen. They would prescribe this to people with eating disorders, so they'd gain weight.
Right. Yeah. Makes sense.
It does on a clinical level, but when you've got somebody that has severe body image issues that doesn't want to gain weight, and they're getting put on this new medication that they're most likely not going to know anything about, because I don't know anyone that gets told the full range of side effects of their medications when they're put on them. I never get told, and a lot of my clients never get told. You have someone with a severe eating disorder being put on this, they're suddenly ballooning in weight. I don't think it's them.
Yeah, and it's the medication that's doing it.
Yeah. And I use that as an example. I don't use that as, aha, gotcha. Don't take this. No, because it's sadly, mirtazapine is one of the more effective antidepressants, and it has one of the better side effect profiles. So you're not going to be riddled with as many side effects.
Yeah.
But I think massive weight gain is not a trade-off that should be acceptable. Now, ketamine, as an example, Again, for someone with treatment-resistant major depressive disorder, again, it's used increasingly for PTSD, sometimes bipolar 2, anxiety disorders too. It doesn't really have any long-term side effects.
No.
At all. There's a lot of research behind this. I'm just going to bring up my documents quick. Just looking for them. But the most severe kind of side effects you have is you might have a mild anxiety attack, because in the very rare cases, because of the nature of it.
Yeah.
Or the most common side effect, should I say, go with is, because that's a rarer side effect, is a headache, which goes away.
Yeah.
Compared to sexual dysfunction, which happens on most, if not all, SSRIs, and a lot of other psychiatric medications that are commonly prescribed, which can be permanent, by the way. Not always, but it can be permanent.
I just wanted to touch on one other point. Actually.
Sorry, I'm kind of rambling now.
Sorry.
The point with that, I'll wrap that up. The point with that is these treatments don't. There's no drawback to them. There's no. There've been several studies that have been done, because people's fear are we're putting somebody on a controlled drug. Are they going to get addicted to this? The same with psilocybin, so magic mushrooms, which is another one that works in a very similar way to ketamine. Again, there are clinical trials that are happening with that. It again works on the same areas of the brain in a nutshell. There are no drawbacks. People don't become addicted to these drugs because they're given in microdose levels a little bit, but
that's okay. So what I was wanting to touch on was, you mentioned obviously treatment-resistant depression.
Yeah,
is the sort of pathway for that diagnosis is failure to respond to 3 or more SSRIs, isn't it?
Yeah. So they say in the NICE guidelines, they say it's free. Does that happen though? I don't think it does. It might happen in rare cases when you get a competent clinician overseeing you, but how often does that happen? Let's be honest.
Yeah.
But I would say, as a patient, a lot. I think the mental health system, and it's not any particular practitioner. I think the way the mental health system is structured is it beats you down until you feel powerless, because there are long waits. The people you see aren't always very friendly.
Yep. Yeah.
Don't always get on with them. Sometimes they are even abusive. Not always, I'm not tarring everyone with the same brush. There is some genuine excellent care that I've seen out there, and I've seen a lot of it. I mean, I used to be I was a CQC inspector, Care Quality Commission, so I inspected subcontracted, not within the CQC, but as part of it.
Yeah.
As a patient expert, would inspect hospitals and NHS trusts all across the country, and there is some genuinely excellent care there. Typically tends to be the further south you live, not always, but typically, because there's more investment.
Well, thanks again, folks, for listening to episode 4. You just listened to episode 4 with Zachary Kellerman, who is a former therapist with some psychiatric training. We talked on a lot of different things, a lot of different topics, including his own personal story with mental health, treatment-resistant depression, and the different types of medication that he's been on, and the different types of therapies that he's explored, including partaking in a clinical trial to do with ketamine and things like that, the treatment of the treatment-resistant depression there. We've talked about advocacy, advocating for yourself and complaining when it's right to do so, and about fighting the system. But also he's talked very passionately again about the ketamine and having it widely available for people where, they've maybe lost hope and they've tried a lot of different things and they don't know where to go or what to do or what solution is best, guys. So that's what we've talked about in this episode. There's a little bit more to it than that. This is only a small excerpt of the full episode. You can find the full episode on the appropriate channel when I've released it, guys. It's about 2 hours long. It's a really good listen though, so I'm going to split it up into 2 parts, guys. Okay. So I hope you got some value out of this, and it's a real honour and privilege to have Zach on the podcast. So thank you very much, Zach, for agreeing to come on the podcast there. But that's everything, folks. I appreciate it if you could like, comment, share and subscribe across all our channels. We've got a Facebook page, we've got a YouTube page as well, and I'm slowly migrating all of our episodes onto that page, guys. So thanks again, folks, and bye bye for now.